Hello, this is Asia Place, Level of Care Manager at the Center for Balanced Living. Today I'm going to be talking about kind of how to refer your clients to our higher levels of care and kind of what the level of care admission process looks like. And this is to answer any questions that we have received from other providers in the community regarding how this process works. So we'll start with what the intake process looks like here at the Center for Balanced Living. So we would start off with a client calling the center at the main number or the front desk number, which is 614-896-8222. They will talk to one of our front office staff who will just get some basic information regarding what their insurance is to make sure we're in network, get some demographics, and then they'll also do like a mini evaluation or assessment screening process to then triage them either into outpatient or into the level of care process, or to see if maybe outside providers or referrals would be more appropriate. The client themselves is the one that needs to call in unless they're a minor, and then a parent or legal guardian can call in for them. But eventually the level of care team or the outpatient therapist will need to work with the minor. If you are a provider in the community, your client needs to call in themselves. The next step is the front office staff will then triage and place that client into our system regarding the mini evaluation they did, either putting them into outpatient or moving them forward in the higher level of care process. If the client is triaged for outpatient, the front office staff places them in our outpatient waiting list, or what's called our queue. The clinician in the outpatient then, who has room in their caseload and takes that client's insurance, will reach out to that client and schedule a 1-hour face-to-face diagnostic assessment. After they do the assessment, they'll start seeing each other and working together if appropriate, anywhere from 2 times a week for an hour each, maybe to as less as 1 time every other week, kind of depending on the client and their needs. And they could work together anywhere from months to years. And then the outpatient therapist would get them in contact with any other services in outpatient that we have, like as adjunct services. If the client is triaged for a higher level of care, if we're looking at either intensive outpatient, a partial hospital program, or even a higher level of care that we don't offer, the front office staff will contact me, the level of care manager, with that client's information. I will then assign the case to either myself or one of my level of care clinicians. We have Kristen Howell, Stephanie Ike, Samantha Totora, and M. Mullen. And then that level of care clinician, whether myself or one of the other 4, will call the client to schedule a 30-minute phone screen. The phone screen, like I said, is about 30 minutes. It can go up to 60 minutes depending on how much information needs to be gathered and how much the client is disclosing. But what we will do is reach out to the client within 1 to 2 business days after they've called the front desk. So we do need a correct phone number to be able to reach them at. And the client does need to either answer or have a voicemail set up and return our call as soon as possible to get that phone screen scheduled. And then we'll also need to be able to reach them for the actual phone screen that is scheduled, because we call them at that time to do the phone screen. At the end of the phone screen, if we feel that they are intensive outpatient appropriate or partial hospital appropriate, we'll then bring them in for a face-to-face diagnostic assessment to get more information. This is about 2 hours. We try to schedule it within 1 to 2 days from the phone screen. It's mainly building on the phone screen, getting more information regarding their history, where the phone screen is more symptoms and behaviors in the last 3 months. This diagnostic assessment is also looking at any comorbid diagnoses. And then at the end of the assessment, what we'll do is get their height and weight. It is a blind weight. We'll do some more paperwork, and then we'll give them our final recommendation and kind of orient them to that program and answer any questions or concerns they may have and fill them in on what the next steps are in order to then admit to that program that we're recommending. One of the steps that they'll need to complete after the assessment to be admitted to our program is getting medical testing done. We will provide them with the form that's signed off by our MD, Dr. Tackett. They can take this to their primary care physician or turn urgent care. Upper Arlington Urgent Care seems to be the one that works best for our clients. They do all the tests right there. They take all major insurance, and they get the test results back to us pretty quickly. It includes a full panel of blood tests, an EKG for their heart, a full physical, and then a medical stabilization sheet that needs to be signed off by the medical provider that ran the test, stating that this client is medically stable to then enter treatment at the Center for Balanced Living. We have to have all 4 pieces before we can consider admitting them. These results then will be collected by the level of care clinician. Once all 4 pieces are collected, they're then turned over to our MD, Dr. Tackett, or a psychiatric nurse practitioner to review. They will then give them the clear, saying for sure if they're medically stabilized or not. They have to be medically stabilized to admit to one of our higher levels of care. If they are not, they will then be referred to residential inpatient, or if it's something pretty severe, to the ER in that moment, or if it's a specific issue, they'll be referred to a specialist. Like if it's a heart issue, they'll be referred to a cardiologist. And the last piece of the intake process is the insurance. So while they're in the 2-hour assessment, our billing director and front office staff will be calling the insurance company to get the client's benefits. And we'll meet with them at the very end to go over what the insurance is going to cover and then what they will be responsible for financially, the difference regarding what the program is going to cost after insurance pays their part. Then the day the client actually starts treatment, a clinician in that program will do the insurance pre-authorization call. We'll get the insurance to approve at least anywhere from 3 to 10 days, depending on the insurance and depending on the program. And then we'll continue to do the reviews with the insurance company to get more days. So now moving on to criteria for each level of care or each program. So you know when to refer and what program that your client's probably going to be looking at. For outpatient, which is just seeing a therapist like twice a week or once every other week, and then maybe like a dietitian or somebody for medication management, to meet criteria here at the Center for Balanced Living based on insurance companies and then the American Psychiatric Association, their BMI needs to be greater than an 18.5. Any behaviors like binge eating or any types of purging behaviors have to be less than 3 times a week. And then that they're also pretty high functioning. They're functioning well in most areas of their life. The admission criteria for our intensive outpatient programs. This is usually when a client needs a little bit more structure than just seeing an outpatient therapist and dietitian like once a week or as needed. They need occasional supervision and support, mainly around meals and snacks, and more accountability, especially around preventing and abstaining from other behaviors like excessive exercising, purging by vomiting, purging by laxatives, diet pills, diuretics, binge eating. They'll need more support, especially benefiting from being in a group setting, learning from other clients, being validated by other clients. They do need to be medically stabilized, and they can have comorbid diagnoses, and these will be addressed during the eating disorder treatment. Although we specialize in eating disorders, we are a mental health facility and can treat their comorbid diagnoses as well, but the eating disorder is usually primary. And with purging or laxative use, diuretics, diet pills, exercise, there might be some ambivalence, and also they might have some difficulty reducing the frequency on their own, so they would benefit from a higher level of care. They are able to contract for safety, though, and do not need monitoring for any suicidal ideations. Their BMI would be a 17.5 or greater. If it's lower than a 17.5, it would be partial hospital appropriate. And then behaviors, whether purging types behaviors or binge eating, would be anywhere from 3 times a week to 5 to 6 times a week. Any more than that would be partial hospital. Any less than that would be outpatient. And again, this is tentative to what specific insurance company they have, but this is usually the general guidelines that we follow. And then the admission criteria for partial hospital. These clients, we need to prove that they would benefit from a 30-hour-a-week program that is full of a lot of structure, support, and accountability. Some insurances require proof that the client has failed at a lower level of care and that partial hospital is absolutely necessary. The client usually does have some medical or physical symptoms or complaints, but they're still medically stabilized. They have to be cleared prior to admission. But we need to prove that they need to see the nurse daily for check-ins, which would be for their weigh-ins and their vitals, and that we also need to prove to the insurance company why they need to see a doctor once a week while they're in partial hospital. In this program, we're more likely to treat the comorbid diagnoses, and almost all the clients in this program have comorbid diagnoses. But again, the eating disorder is primary. For those with anorexia nervosa, we take BMIs in this program from 15 to 17.5. Clients that are lower than a 15 are typically not medically stabilized, so therefore we refer them to inpatient or residential treatments. And then behavior-wise, whether binge eating and or any types of purging behaviors would be anywhere from 5 to 6 times a week to multiple times a day on average in the last 3 months. If it's more than like 5 or 6 times a day, or there's many different types of purging behaviors going on at once, they would be referred to a residential or inpatient facility. Also, to meet criteria for partial hospital per insurance companies, client is unable to function in 2 or more major areas of their life, and we have to prove that and be specific about how this is affecting these areas of life, whether school, work, social life, the ability to take care of themselves, the ability to take care of their family, finances, etc. If there's a history of substance use or abuse, or they're currently using, they must abstain to be in this program. If they cannot abstain, then we have to refer them to a drug and alcohol assessment with people who are specialized in drug and alcohol treatment. Once they have that assessment, they have to prove or show proof of what was recommended. If the drug and alcohol facility is saying that the eating disorder is primary, we can then treat them. If they're saying that the drug and alcohol issues need to be treated first, that has to be successfully done, or they have to successfully complete that recommendation or that program before returning to us, and then we will coordinate and consult with the drug and alcohol facility. Clients in partial hospital, they can have suicidal ideations, but they have to be able to safety plan appropriately. If not, they would then be referred out to like an ER or a psych hospital for medication management and monitoring for safety. So when it comes to talking with your client about getting treatment at the center, if you're thinking about making this referral, or you at least want to, address the possibility that the client might not be outpatient appropriate anymore, these are the types of things that may be helpful. So how do we discuss the need for a higher level of care? Most importantly, just state the facts. State what you're observing or what's being reported behaviorally and symptom-wise. And then explain the different criteria for the levels of care and where their behaviors and symptoms fall. Show them or talk to them about why they're no longer outpatient appropriate and what program or level of care they might be meeting criteria for. Then how do you get your client to call? Well, first and foremost, it is their choice. You can't make them if they don't want to. What you can do is be supportive and validate their concerns and maybe any barriers that might be getting in the way to them calling or doing a higher level of care. You can offer your rationale for recommending a higher level of care. You can give them as much information as possible on our facility and our programs. educate them on the intake process to help lower some of that anxiety and ambivalence, and provide our contact information. You may even want to make the phone call with them during the session. That might help them, especially with their anxiety and any ambivalence, and showing your support. Also, it might be helpful if you have them sign a release of information for you to talk with us, if the client, of course, is willing. Then you can call myself. My direct number is 614-896-8228, or you can fax information to our main fax, which is 614-896-8223. And this is regarding information about the client that would be helpful for us to know, any clinical information, and then why you think they're appropriate for a higher level of care. And maybe if you know a little bit more about our levels of care, what program you're thinking your client would be appropriate for. If the client does not follow your recommendation and you are referring them to a higher level of care and you do not feel comfortable holding them at an outpatient level of care due to the severity of their behaviors and symptoms, legally and ethically, you can choose to discharge them as long as you have given them referrals. It is their choice whether they follow the recommendation or not, and it's your choice whether you keep them after that or not. So what can you expect after you refer your client? So let's say you've referred your client, they've started a higher level of care. So what's going to happen while they're in that higher level of care program? The assigned therapist or case manager will be coordinating with the client's outpatient providers throughout the client's stay. The dietitian, more specifically, might be coordinating with the outpatient dietitians. And then your client can return to you as soon as they step back into outpatient. Their case manager or therapist in the higher level of care program will set this up ahead of time, unless insurance cuts them off abruptly, but usually we are pretty proactive in setting all of that up ahead of time for a smooth transition. So lastly, thank you very much for any of your referrals. We want the very best for your clients, and we do appreciate your referrals. Please contact us if you have any additional questions or concerns about this process or about the different programs and levels of care that we do offer. And again, our direct number for our main line for the front office staff is 614-896-8222. And then also there's a lot more information about our programs on our website at www.thecenterforbalancedliving.org. Thank you.